Okay, welcome everyone. So I figured I'm just going to go through these case studies first, and then just ask questions in chat, and then as we go through, we will go through with it, catch everything. Just want to see if chat works. Okay. Making sure everything's working properly. Okay. Okay, so case studies for the second unit. As we're going through them, we'll highlight certain things. Okay, so first case, Thomas L., 28-year-old male, complains of abrupt polydipsia, polyuria. Blood and urine analysis provided the following results. So blood glucose, 93, it's okay. Serum sodium, a little bit on the high side, but it's okay. Potassium is low, urine osmolality low, urine volume is very high. So we have high volume. Okay. So what other studies would you want to do for this patient? Water deprivation test, which does cause significant reduction in the polyuria and the concentration of the urine, I'm sorry. So when you do this water deprivation, you're not giving them any water at all. I'm trying to make sure everything's okay. Okay. So they're not drinking anything. So urine osmolality goes up to 230. However, when this happens, significant concentration of the urine, decrease in urinary output following the administration of ADH. So with all this scenario, what's going on with this patient? Central diabetes insipidus. There's a greater than 50% increase in the urine osmolality after they're given ADH. It's central because the brain is not making or secreting ADH. And because they're not secreting it, the kidneys are still responsive. So once you give them ADH, you see the results. What causes this disorder? Idiopathic, anything really involving head injuries or involving the head. So tumors, cranial surgery, head traumas, all are involved. Treatment for this, refer to endo. Most everything, you go to endo. However, first line, you can give GDAVP. And then also second line is vasopressin to help with the DI. Second case, we have Hazel C., 30-year-old female with subtle onset of the following symptoms. Can you guys hear me? I'm just making sure that no one's really chatting, so I'm making sure people are here. So, 30-year-old female, Hazel, comes in. Subtle onset of the following symptoms. Dull facial expression with droopy eyelids. Okay, perfect. Thank you, Callie. Puffiness of the face, periorbital swelling. So you guys had that OSCE, and one of the cases was a hypothyroid case. So you're supposed to do inspection of the eye to look for any periorbital edema because, again, signs of whatever we're going to be talking about have that same issue. sparse, dry hair, dry, scaly skin, some intellectual impairment, lethargy, constipation, change of personality, and they have bradycardia and low blood pressure as well. So what lab studies we want to order for this patient? Obviously, we get thyroid panel, and the thyroid shows T3 is only 20, and that's your normal reference range. T4 is 2.8, and there's your range. And there's our TSH, 36.5. So we know our TSH is high, T3, T4 is low. That is our thyroid hormone, T3, T4, that's low. TSH is high because the stimulating hormone to get more of that thyroid hormone out. The thyroid's not working, so again, the pituitary gland is going to start poking that pituitary gland to start pumping out some thyroid hormone, but obviously it can't. So the diagnosis in this case is hypothyroidism. Some causes for hypothyroidism and autoimmune disease, your Hashimoto's. But remember with Hashimoto's, they start as hyperthyroid and then they eventually burn out the thyroid and it turns into hypothyroid. Usually by the time you catch it, they're in that downward phase and going into the hypothyroid. Any type of head and neck irradiation, so remember always going to the dentist, they always cover the neck with the lead to avoid the irradiation of the thyroid and any previous postpartum thyroiditis. Treatment, they're going to be either levo or synthroid, and remember to tell the patient that this is lifetime. Okay, they won't be stopping this thyroid medication. Okay, so this is a good summary slide to make sure you know when it comes down to like hyperthyroidism, primary hypothyroidism, secondary due to pituitary issues. Remember also the tertiary hypothyroidism, that's going to, that's going to deal with the hypothalamus. So it's not on this table, but just remember that that exists as well. So remember your flow charts. You have your boxes that we did in Phys. And then your boxes, and make sure you know all the feedbacks and how they all relate to each one going up. Okay, case number 3. Oscar T is a 45-year-old male presenting with the following signs and symptoms: weakness and fatigue, orthostatic hypotension, weight loss, decreased cold tolerance, dehydration, and increased pigmentation of both exposed and non-exposed portions of the body. So we have hyperpigmentation. Weakness, fatigue, orthostatic hypotension, so we know we're having an issue with fluid because we're orthostatic. Weight loss, dehydration. So let's see what the labs show. Sodium 128, serum potassium 6.3, that is definitely very high. Glucose is low, serum creatinine is it's okay, a little bit high. What other studies we want to order? Plasma cortisol level, and that shows decreased cortisol levels. And plasma ACTH, that's going to be very elevated because there is no cortisol being produced, so ACTH is going to be high, just like with the thyroid, where TSH is elevated because that's the stimulatory. ACTH is the stimulatory to get the cortisol out. So with this patient, you give them ACTH, and plasma cortisol did not rise significantly after 90 minutes. So at this point, what is your diagnosis? This is Addison's disease. And what causes this disorder? It can be autoimmune issues, TB, Hodgkin's lymphoma and non-Hodgkin's, and also some of your metastatic cancers as well can cause these. So what's the treatment for Addison's disease? Hydrocortisone, Florinef, and prednisone are examples. Hydrocortisone and your prednisone are your glucocorticoids. Okay, do not stop. Okay, they can't stop this. And also, you have to remind them if they're sick, they have a fever, going for surgery, big test coming up. You want to do it for that, but surgeries and so forth, they need to take an extra pill, take more steroids to handle that stressful situation. Because remember, with stress causes cortisol to be released, which handles the stressful situation. If you're in a stressful situation, your body can't produce cortisol, so you don't have that ability to help you with that. Florinef is your volume expander. So this is going to mimic with the aldosterone. Case number 4. So we have Horace C., a 50-year-old male that had a total thyroidectomy, followed by thyroid hormone replacement therapy, so lifetime use of levothyroxine or Synthroid. 36 hours later, after the surgery, he developed laryngeal spasms, mild tetany, and cramps in the muscle in the hands and the arms. What have I been saying with you guys since day 1 of physio? Whenever it comes to calcium, contraction, and exocytosis. So if we're having issues with spasms, tetany, cramps, and calcium. And also, he had a total thyroidectomy. What would you want to know after this? Make sure that they didn't have their parathyroids taken out. So urine tests were performed, following tests were performed. Urine calcium is low. Your plasma calcium levels is 7, that's low. Plasma phosphorus is only 5, is elevated, at a range. So what other studies do you want to order? Let's get some parathyroid hormone because they may have taken everything out with the thyroid. Parathyroid hormone is decreased. EKG shows prolonged QT interval. So what's your most likely diagnosis for this case? This is your hypoparathyroidism. The causes, status post-thyroidectomy, again, any type of surgery in the neck, radiation, so forth. So that's all affected with the parathyroid hormone. Treatment, airway management, IV calcium, mag sulfate as well, helps stabilize the cardiac muscle cells. That also helps with that. And eventually they're going to need, some parathyroid transplant. They put them in the arms. They put some parathyroid tissue in the arms, the forearm, and it gets access to the blood. And the receptors are still there for calcium, so it knows what's going on, and it'll still release parathyroid hormone. Next case. So a 39-year-old female complains of numbness of the hands, excessive sweating, unpleasant body odor. She also marked she has gained some weight, and her ring size has gone up as well as her shoe size. So by the time you're 39, you've pretty much stopped growing. You're not going to grow anymore. So she's gaining weight, her ring size went up, her shoe size went up, which means they're getting bigger. Hands and feet really shouldn't be going on. Upon your exam, you notice the following: thick, oily skin, impaired vision, headaches, fatigue, weakness, and some menstrual cycle abnormalities and breast discharge. So obviously she's got something going on in the brain that's causing the headaches, impaired vision. And we all know that obviously the pituitary gland lies right by that optic chiasm. So that's why it causes some vision issues. So what studies do you want to do? You can do a glucose tolerance test with growth hormone levels at 3 hours to see what's going on there. Because obviously we're thinking about acromegaly in this case, excessive growth hormone secretion. So growth hormone level it measured was 16.3. The normal is less than 5. GHRH levels are very, very low because there's a ton of growth hormone being released, and therefore we don't need very much growth hormone releasing hormone being released. IGF levels, very, very high. Remember, growth hormone causes IGF-1 to come out, and that's what causes all the growth, is really the IGF-1. And blood pressure is elevated compared to normal population. So diagnosis in this case, acromegaly, and remember the big difference between acromegaly and gigantism is the growth plate closes. So what causes this disorder? In this case, pituitary tumor, excess IGF-1 caused by the tumor. Treatment, refer to endo. That is not going to be an answer on the exam tomorrow. I'm sorry. You'll have to know the real answer. But again, surgery if the adenoma is there. Dopamine agonists are going to stop the affect that. Bromocriptine and cabergoline are the two big ones. Octreotide is another one that you can use as well. But bromocriptine is usually the first line for acromegaly. And surgery, obviously, if they have a tumor. Next case is Susie B. She's a 3.5-year-old female brought to the clinic by her parents who were concerned about her slow growth, night sweats, and craniofacial abnormalities. So upon observation, she has a protruding forehead, small chin, delayed teething, sparse hair. Slow motor development was also observed. So what kind of studies would I like to order for this patient? Some glucose, sodium, growth hormone, and this should be IGF-1. Obviously, these are low because the patient has growth hormone deficiency. For this patient, she's not growing as well as she should be. Cause, again, absence of growth hormone secretion. And the treatment for this patient, yes, refer to endo, but we're not going to do that. We're going to give human growth hormone and just restore the normal levels of growth hormone and reduce the morbidity from growth hormone deficiency. Remember, with this, you're just getting them back to a normal growth curve. You're not going to make Superman out of your kid by giving them growth hormone at a young age. It's just making them grow at a normal speed, and they'll be back to normal, within normal ranges for their age. Next one, case 7. We have Grace S. is a 58-year-old female, chest pain, palpitations. Okay, progressively getting worse for the past 3 months. She claims that she's nervous, irritable, has difficulty sleeping, has trouble controlling her emotions. Chest pain is non-radiating and not related to movement. Experienced 10-pound weight loss and is hot all the time. So, what studies would I like to order in this patient? Thyroid panel. She's losing weight. Hot all the time. Motions are trouble controlling chest pain, palpitations. So we do her thyroid hormones and we can see that they are elevated. TSH is very low because we don't need TSH because we have so much of our thyroid hormone being released. We did some antibodies and we found that our TSHR antibody is positive and the TPO is negative. So when you're studying, TSHR antibody is for Graves' disease. It's going to sit in that receptor and turn on that thyroid gland to keep pumping out thyroid hormone. TPO is looking at Hashimoto's. EKG shows atrial fibrillation. So obviously this thyroid hormone is making them go into atrial fibrillation. So what is the diagnosis? This is Graves' disease, hyperthyroidism. She's positive for the antibodies. What is the cause of this disorder? The TSH receptor antibodies. It's an autoimmune disorder as well. Treatment, refer to endo, but we're not going to do that right now. Possible surgery. You can give methimazole or PTU. Make sure you remember which one is for pregnancy. And you can also do a possible thyroid ablation with iodine-131. Case 8, Virginia T, 47-year-old female, well-developed, obese woman with a rounded face, back pain, fatigue, muscle weakness, several bruises on her arms and legs that she reports happen all the time when she's barely hit something. 20-pound weight gain over the past 2 years, mostly evident in the stomach and the face. We have a redistribution of body fat. Face is rounded, so the moon face, rosy cheeks, abundance of facial hair present in the chin, upper lip, and side of her face. So what studies would you like to order? Urinary free cortisol level is elevated. So we have a lot of cortisol going on. We did a dexamethasone suppression test. Low dose shows no suppression of the pituitary gland. High dose dexamethasone, no suppression of the pituitary gland. Evening serum cortisol level is elevated, and the ACTH is elevated as well. So we have high ACTH, high cortisol, no suppression on the dexamethasone suppression test. Okay, so after the high dose dexamethasone suppression, it may be possible to make further interpretations. So if ACTH is elevated and cortisol is not suppressed by low doses and is suppressed by high, you have Cushing's disease. It's at the pituitary. But in this case, we have this going on. Elevated ACTH, not suppressed by high or low doses. This is an ectopic tumor that's producing ACTH. Remember, the adrenal glands don't know if the ACTH is coming from the pituitary gland or if it's coming from one of these tumors. It just gets occupied, the receptors get occupied, stimulating cortisol to be released. Doesn't matter where it's coming from. So in this case, this is Cushing's syndrome. Remember that this is not disease. Cushing's disease is only the pituitary gland. That's it. But Cushing's syndrome encompasses the entire thing. It could be pituitary or ectopic and so forth. Cause of this disorder, again, this is an ectopic ACTH secreting tumor, either from the lung or a carcinoid tumor. Treatment, refer to endo or oncology. Again, they need to get this tumor removed and get this chest CT for looking for the lung CA. So Cushing's syndrome, treatment and management, they're going to have to go to endo and neuro. Surgical excision if there's a pituitary adenoma present that's causing this to happen. Or bilateral adrenalectomy if they have congenital adrenal hyperplasia. Again, these are things that you won't know until you go looking. But the dexamethasone suppression test tells you, okay, yes, this is a pituitary problem, and we get a CT of the brain, or no, this is not coming from the pituitary because low and high dose suppression didn't do anything. So I have to start looking for a tumor. So let me do a CT of the chest to make sure that the lungs are okay. Let me get a CT of the adrenal glands to make sure there's no adrenal gland tumor. So all of these treatments are just based off of wherever the tumor is located. So it's not going to be all of these, it's just wherever it's located. Again, pulmonary consult, again, if there's a lung tumor. If they are under excessive use of corticosteroids, okay, for example, if they have like rheumatoid arthritis, they have to be on prednisone all the time. Some people who are on prednisone for a long period of time will get Cushingoid symptoms due to the exogenous use of corticosteroids. That you would have to talk with whoever doctor prescribed her the prednisone or the corticosteroid and talk about how can we wean her off, the patient off or whatever to get them reverse this Cushingoid. May need potassium supplements because aldosterone may be affected as well. And watch out for osteoporosis to prevent fractures. To get your DEXA scans on those patients. Medications, you can give some adrenal steroid inhibitors for these patients. Metoprolol is a big one. It just inhibits endogenous adrenal corticosteroid synthesis. So it just does prevent and slow down the creation of cortisol. Nizoral, ketoconazole, it's an antifungal, but it also helps with first step of cortisol synthesis and will prevent more cortisol from being made. And the last one is this cytidrin, which inhibits the conversion of cholesterol to this pregnenolone. And remember, that actually is the rate limiting step in the whole cascade of making your glucocorticoids and mineralocorticoids. You need the conversion of the cholesterol to pregnenolone. If that doesn't happen, none of the other stuff's going to get made anyway. So that was a Cushing's patient. The next case, and this might be, I think this is the last one for the case, then I'll hang out for a bit, take any questions, and we'll go from there. I do want to try something out though when I'm done with this. It's a poll feature. I just want to see how that works. So, okay, next case. 39-year-old male brought to the emergency room by ambulance. He was found wandering in the street in a disoriented state. He's confused, agitated, and further history is obtained via his wife. She reports the last several months he's been complaining of intermittent headaches and palpitations, and some experiences of lightheadedness and flushed skin. 3 weeks ago, he was diagnosed with hypertension and was started on clonidine twice per day. So remember, clonidine it's an alpha blocker. It'll come in handy later. Okay, made him feel sedated, so he was 5 days ago stopped the clonidine and began metoprolol twice daily. So now he went from an alpha blocker to a beta blocker. So on admission, vital signs: he's afebrile, heart rate 110, he's tachypnic, O2 sats good, blood pressure 215 over 132. Very, 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 very high. In both arms equal, so we know that's the true blood pressure. General exam, agitated, diaphoretic, looking around the room and doesn't really appear to recognize his wife, so he has some AMS. Pupils are dilated, but they are reactive. He does have papilledema and some scattered retinal hemorrhages, so there's obviously all that pressure is causing an issue. No thyromegaly, so the thyroid's okay. We're not have to worry about no thyroid storm. Because thyroid's, well, no thyromegaly, obviously that doesn't matter, but we'll get the labs later. Heart, lung, abdominal exams are okay. Pulses are bounding, but they're equal in both arms. And he moves everything, so neuro is intact, but a little tremulous from all the stuff floating around in his system, which we'll talk about in a second here. So due to his altered mental status, a non-contrast CT of the head is done, and it's negative for a hemorrhage. Good, we don't worry about popping any arteries due to that very high blood pressure. Lab studies has a normal leukocyte count and hemoglobin of 16.5, which is a little bit high. Sodium 139, potassium 47, chloride and bicar are 29. B132, creatinine 1.3. Urinalysis is normal, drug screen is negative. Lumbar puncture is performed, CSF has no cells and normal protein and glucose. So there's no other reason for the papilledema. As far as we ruled out any type of neuro, brain cause, structural cause. Now let's worry about what else could be causing this spikes. So studies we want to perform: 24-hour urine collection for creatinine, total catecholamines, VMA, and your metanephrines. Remember, the VMA and metanephrines are a result of the breakdown of the epi and norepi. So if you have too much epi and norepi, the breakdown of it is going to cause a higher amount of VMA and metanephrines in the urine that we collect, as well as having high total catecholamines as well. Obviously, yes, they're going to be elevated, and you do your scans, and it shows a tumor in the medulla. And we know the medulla is what pushes out all your catecholamines. So your assessment of this patient is a pheochromocytoma. Plan for this patient, get rid of the tumor. Now, remember, it's always alpha blockade first, and then you block the beta receptors. You don't want unopposed. It causes a bunch of issues. So always remember alpha first. So you give the clonidine first, and then you give the beta blocker or metoprolol, but give them together. You just watch the heart rate, but obviously we're more worried with the pressure. And we got to block these catecholamines from having their effect. So that's the big thing there. So that is it for the review that I had for the cases. I'll stick around for a little bit if anyone has any questions specific that I kind of didn't go over or allude to. I do want to try this poll, though. So whoever's here, though, if you're watching, I want to see how this works just for future streams. Okay, let's see how this works. Yep, okay. Why is this not working? Okay, I don't know what you guys see on your end. I don't even know where you guys vote on this, so. But I'll try and figure this out. Okay. Okay, so it does show up. Okay. Okay. I'll have to figure that one out. So anyway, if anyone has any questions, let me know, and we can go over them. If not, we'll end early tonight. Okay, thanks, Kelly. I got to figure that out. I don't know how that works. There's no way for me to test that out, but.
I know it sounds silly, dear, but do it for me, please.
Okay, MEN tumors. Okay, it'll come up here in a second. Okay, this is the big one to really know. Okay, MEN1, parathyroid issues, pancreatic issues, and the big one are those facial angiofibromas. They're going to have some sort of facial, the fibromas, little things on their nose and the nasal areas, the folds. So if I mention anything about having a parathyroid hormone issue and they have the angiofibromas on the nasal folds, MEN1. It's the only one that's got facial stuff. Is just MEN1. I'm not going to trick you guys on a quiz, not an exam, and not give that part, which is important for MEN1. MEN2A, and also the other important thing with MEN1 is it has that menin gene. And that's the big thing too. They have the deficiency in that menin gene, and that causes they have that MEN1. In 2A, medullary thyroid carcinoma, MTC. They're going to have that. Now, MEN2B also has it as well. But the key thing between the two, intestinal ganglioneuromas, you're going to have more common GI issues with MEN2B. So you got some GI involvement with MEN2B, and they have a little more higher rate of having a PHIO as well. With 2A, they don't have any of the GI involvement. So any question, there won't be anything to do with the stomach. And again, don't read into these questions. It's not going to be there. Just whatever I give you is what you need to know. And the last one is MEN4, which is similar to MEN1. The key is no menin gene problems. Also common for thyroid adenomas, parathyroid issues, pancreatic, and pituitary issues as well. So this is a big thing. Just know this chart regarding MENs 1 through 4. Know the keys for each one. And just remember those, the key differences between the different ones and which ones have the key features that are present. Mm-hmm. You're welcome, Emma. Any other questions? Is there a Kahoot? Let me see. Let's see. I don't think there was one because I would have had it saved in Canvas. And there wasn't one. So let me just look, I'm loading it up right now. Nope, that's the diabetes one. Yeah, I don't have one for this section. No Kahoot. Well, anyway, if you guys want, because I'm going to be doing reviews over the summer for physio again. And I'll do that with them every other week or so. Then if you guys want reviews on different things, we can go over other specific topics. Okay, okay. So Conn syndrome is specifically primary hyperaldosteronism. So we have too much aldosterone due to a tumor that's secreting aldosterone. So adrenal aldosteronoma, remember the layers of the adrenal cortex that secrete the different steroids. And if the layer that makes the aldosterone has a tumor, it's going to produce a lot of aldosterone. So primary hyperaldosteronism due to a aldosterone secreting tumor is Conn syndrome. It is basically hyperaldosteronism. So think about, again, what does aldosterone do? Aldosterone increases the absorption of sodium, and it increases the secretion of potassium. So now we have too much aldosterone. So treatment for aldosteronoma is just surgical. I need to do better with it's too dark, even for you guys. And treatment of choice for the iatrogenic adrenal hyperplasia is medical therapy. So with primary, where's the one I'm looking for? It's not here. Okay, with primary hyperaldosteronism, we have an aldosterone secreting tumor right here. And that's just pumping out aldosterone like crazy. All this aldosterone causes increased sodium retention and further potassium loss. Now, because we have sodium retention going on, we know water is going to go with it. And if we're pulling in back water, our blood pressure is going to go up. Sorry, excuse me. Blood pressure goes up. Renin secretion goes down from the kidneys because the macula densa is going to sense we have adequate blood volume and pressure. We don't need to be releasing renin, which is going to start the whole cascade. We don't need to do it. So in primary hyperaldosteronism, they have high aldosterone but low renin. That's primary. So what we want to do is go to this, actually. Okay. Primary. High aldosterone, low renin. In secondary, hyperaldosteronism, they have high aldosterone and high renin. So think of the underlying causes for this. The most easiest one to remember, renal artery stenosis. Okay, in this case, here's our kidney. We got blockages. In the renal artery. So all this blood gets stuck there, and less blood gets into the kidney. Less blood into the kidney increases the renin because the macula densa doesn't sense it, which starts the whole RAS cascade, and eventually we're going to have high aldosterone. But because of this problem right there with the renal artery, the kidneys are tricked into thinking that we have low blood pressure. So it's going to dump out all this renin, causing secondary hyperaldosteronism due to simple blockage. These patients will not respond to blood pressure medications because the aldosterone is always going to be released. So hopefully that answers your question about Conn syndrome. Next one is about our dexamethasone suppression test. So we have on low dose dexamethasone suppression, and we have the high dose. On the low dose, if cortisol decreases when you give this dexamethasone, cortisol decreases, that means pituitary gland is still sensitive. So we're okay in this situation. If the low dose fails to suppress, but actually, let me just get rid of this for now. We'll do high dose later. So low dose, nothing happens. So at this point, pituitary is not sensitive. So we do a high dose. And when we give the high dose, if there is suppression, that tells us it's the pituitary gland, because at the higher dose dexamethasone, there's still some tissue, some receptors in the pituitary gland that is still receptive and will shut down things to slow down the release of cortisol. That's due to the high dose dexamethasone. If the high dose does not suppress the release, so we give high doses and nothing is happening, that means if high has no effect, there's an ectopic source, because the ectopic cells have no receptors for cortisol. They're not responsive, they're not sensitive to cortisol, they have no receptors for cortisol, they're just dumping out ACTH like crazy. So if the high dose has no effect at all, it's an ectopic source of the hypercortisolism. If the high dose is suppressing it, that means the pituitary gland still has some receptors that are sensitive at higher doses. So we know that the issue is the pituitary gland when the high dose does have suppression. So I hope that answers your question, Kaylee, about that with regards to the dexamethasone suppression test. Any other questions? Okay, well, if there's no more questions, we're going to wrap up here in a minute. So the case studies that I went over are posted in the modules. They're there as well. And then we went over it together, so you can watch it. Okay, I'll see you all tomorrow. Have a good night. Good luck.